Welcome everybody to our TIF Talk Tuesday. My name is Andrea Millers with Endogastric Solutions. Thank you for joining us this evening. We're very excited to have our very special guest, Dr. Hiral Shah. Dr. Shah, thank you for being here this evening. We appreciate it.
Well, thank you for having me.
Yeah, so before we start, I just want to remind everyone this is a live event. So at any time, if you have any questions that you'd like to ask the doctor, please go ahead and type the question in the comment section and we will do our best to answer all of your questions. So before we start, I do want to give you a little background on Dr. Shah. He earned his bachelor's degree from the University of Washington and his medical degree from St. George's University School of Medicine. He served as chief resident during his internal medicine residency, and he completed his gastroenterology fellowship at Washington Hospital Center, Georgetown University Hospital in Washington, D.C. Subsequently, his fellowship in advanced therapeutic endoscopy was completed at Fox Chase Cancer Center in Philadelphia. Dr. Shah is board certified in internal medicine and gastroenterology. He is a fellow of the American College of Gastroenterology, the American Society of Gastrointestinal Endoscopy, and a member of the American Gastroenterology. His areas of expertise include gallbladder disease, gastroesophageal reflux disease, otherwise known as GERD, and pancreatic disease and stomach disease. He practices in Allentown, Easton, and East Stroudsburg. Did I say that right, Dr. Shah?
Yep.
Perfect, in Pennsylvania. So again, welcome, Dr. Shah, and thank you for being here tonight.
Thank you again for including me and having me. This is fun.
Yeah, absolutely. In addition to that, we have Wendy Profit from Endogastric Solutions as well, and she will be joining us to help answer any of the questions that pop up from our Facebook fans. So let's go ahead and get started, Dr. Shah. We're here to talk about GERD. Can you tell us a little bit more about what is GERD and what do potential patients feel if they are suffering from GERD?
Yeah, it's great introduction to this talk today, and thank you again. We see reflux disease every single day. It's an enormous complaint nationally, worldwide, and typically patients can present with a variety of symptoms. Some patients simply can present with the classic kind of presentations that we talk about. Oh, I need my Tums. I've got this heartburn. I just ate some spicy food, but it happens repeatedly. It happens day to day. It happens in the evenings, mornings, and it's kind of turns into a chronic, recurrent issue for many patients. Some are very occasional and have these types of heartburn types of issues and complaints. Some feel, and it's not uncommon to have patients feel like they're having a coronary related issue or a cardiac issue. And it's important to obviously be cognizant of that and rule those, critical issues out as well. But to know that many of the patients that present will actually be presenting with these types of symptoms where the cardiac workup will be negative. And that's why we talk about heartburn, the burn of the heart, but it's really an acid phenomenon or a reflux phenomenon. And then there's the atypical things. People will complain of sour brash in their mouth, or they may complain of, cough, which is a variable kind of a complaint with patients that have what we call laryngeal-pharyngeal reflux, or reflux in the oropharynx, in the mouth, so to speak. They may feel like acid is creeping up. So there's a variety of complaints and symptoms. The classic will always be the kind of the heartburn related complaints. Some people will just have epigastric pain, and a lot of folks will mask some of their symptoms with just routine antacids and such, and have these kinds of complaints, for years. So no one shoe fits all. Everyone kind of has their, different presentations, but folks do, generally have kind of chronic persistent issues and should probably seek, opinions and workup and evaluation in these types of settings. So.
Yeah, perfect. Thank you. And, what do you tell patients to do to manage their GERD, right? There's all these different, prior to even getting into medical therapy, lifestyle changes, diet changes. What are those things that you recommend for patients to do if they are suffering initially with GERD?
I love that question because I think I'm a big proponent of general health. I am at heart an internist to begin with, and I think that there's a lot we can do. There's we can certainly be better to ourselves. We can certainly eat properly, and everyone has kind of the sweet tooth or the overeating tooth or whatever you want to call it. Everyone wants to indulge. We're all human, and so. But it is important to be cognizant of these things. I mean, smoking and alcohol are certainly risk factors, and does that mean you can never have a glass of wine? It's not necessarily as simple. A lot of times things can be, toning things down, maybe perhaps limiting, perhaps timing, which could be a big issue if you sleep immediately after eating. People talk a lot about putting extra pillows at night and such to elevate the head of the bed. And there's certainly triggers of foods. I mean, we can all probably relate to a heavy, big Italian meal, perhaps, and feeling kind of bloat, gas, discomfort, and reflux type symptoms on a late evening, and top it off with a double espresso or something, and folks are, so these are classic things. I mean, I think on a day-to-day basis, I tell folks start walking. If you don't have to start running a marathon, but I think if you walk every day, 20 minutes, 30 minutes, that's a great start. It's very good, especially if you do it after a meal. Try to cut your meals off early in the day. So that doesn't mean, the 10 p.m., 11 p.m., but, closer to the 7 o'clock time frame. Getting good sleep is very important to reflux. They're really associated. Sleep habits can make reflux worse, and reflux can make sleep worse. So they go hand in hand. And all these things are really a big issue worldwide. And we need to probably tackle them in a much more, all-encompassing way. But I think there is no doubt, people that have, high BMIs tend to, or central obesity, so people that tend to have a heavier weight distribution in the abdomen also tend to have more reflux. So, all these things can be important. Lifestyle is huge, and I think it's a great thing because I think you should start there. And kind of think about the things that you can make changes for. And I'm a huge proponent of advocating for these types of modifications.
I love that. Yeah, thank you. Thank you. And, the question we always get from patients is, how do I know when I need to do something more, right? What do you recommend? If a patient, to your point, you always say, everyone's living their lives, and every now and then I'm going to have heartburn if I eat a big meal or drink, too much or whatnot. But when is it the right time for a patient to make a decision to come see whether it's their PCP or even their GI, and say, this is bothersome? Is it happening 1 or 2 times a week? Is it happening every day? At what point should they be somewhat concerned and start making steps to the next level of treatment, if you will?
Yeah, importantly, not to neglect important warning signs that are certainly worth aggressive interventions or evaluation with your primary or GI. you know, when symptoms are persistent, when symptoms are very rare or occasional, we are not going to probably think too much about it. When it's already planted in your head that it's bothering you, when it's already becoming a lifestyle issue to an extreme, or the modifications don't work, and they're recurring issues of these symptoms despite the things that you've done. And I don't think 3 months of a trial is I think that could be a bit long. I think if you try it for a month, I think you're a healthy person in general, or you're trying to do your best and you to reduce smoking and alcohol. We do have to remember that there is always the scary stuff that we have to think about too. As gastroenterologists and as patients, we do have to worry that there could be more damage in the esophagus. Could there be precancerous type of features? So alarm symptoms to us are really persistent symptoms that are especially refractory to lifestyle and antacids and such that are recurring on a daily basis. And then the things that we worry about, people should not be losing weight because of this symptom. They may want to lose weight to help them, but they shouldn't. The symptom of reflux or heartburn should not be resulting in weight loss, because that tends to be a concern that we need to look into. Trouble swallowing, things getting down properly, are things that are a bit more of a concern. And obviously, if regurgitation or vomiting and such is a repeated issue, these are things that are hopefully brought up in routine healthcare screening with primary care physicians, but if able to or needed to be, can be evaluated with gastroenterologists. So.
Yeah, perfect. Thank you. And before we talk about treatment options and start talking about medical therapy and gradually talking about surgery, we do have quite a few questions that are popping up. So Wendy, I'm going to let you jump on and get through some of those questions if you don't mind, Dr. Shah.
Absolutely.
Fantastic. Oh, you're on mute, Wendy. Sorry. The classic.
Thank you so much. Sorry about that. Lots of folks on this evening watching, so thanks to our audience. I have a question from Francis, who asks, how do I know if my GERD is caused by low or high acid?
That's great. And it's an important question. So typically, the classic scenario for reflux is acid. Acid is made in your stomach, and it's generally released with food. So when we eat, the stomach releases acid to digest the food. That then is really important. The acid is important to our digestive system because things digest and pass down through there. It's when the acid creeps the other direction that we per se believe that you could have an acid reflux issue. There are evaluations that can be done for that, and they typically are pH acid testing mechanisms for that. So whether there's a probe that can be placed in the esophagus, which is a pH probe that can measure acid for 2 to 4 days even. That's the simplest kind of a testing mechanism to evaluate for actual acid. There are other methods of evaluating for acid, and there's also an acid and non-acid test at the same time, which generally requires a pH probe to be placed into the esophagus. So there are ways of testing for acid. Typically, again, the majority of folks will have acid reflux, and so that's what we're seeing. But they can be tested for acid as well. There's also standard imaging, such as X-ray tests, which will show reflux coming up into the esophagus, and that again could be acid, could be non-acid, but that would at least show that real time. And then there's if there's erosive changes during endoscopy in the esophagus, that can be looked at and potentially biopsied and looked for features that are consistent with acid reflux on biopsy. So this is not measuring acid. As a purist, you really want a test that would check for that. So there are test mechanisms for that.
Perfect.
Very good. And that actually leads to a question that Matthew had asked, which is, what do you do to diagnose GERD, and is it invasive?
So invasive is somewhat relative, I think. These tests are generally low risk procedures. To diagnose acid reflux, first off, history. When we talk to our patients, we ask them, what's going on? What are you up to? What are your symptoms? Do you take an antacid every day? Does it help you? Are these the things does it help you 20%, halfway? Is it a problem for you on a day-to-day basis? And so again, the history is still important, but to do a formal evaluation and a formal diagnosis of acid, indeed, we would place a probe in the esophagus and measure that level, or the probe into the esophagus nasogastrically. Either way, that measurement of time period that we would have that probe in would collect the acid levels, and that is basically an endoscopy, so to speak. So, it's not having an operation. You're not having a massive cardiac, surgery or anything, but it is a procedure. It is done, with anesthesia support, and it's placed generally in a hospital setting. But they're very, generally very quick procedures, generally very tolerated well, and provide a lot of information to the patients, I think, that help clarify their problems.
Excellent. Very good. Thank you. So one last one that we'll ask before we jump back into our discussion is, Lynn is asking, hi, Dr. Shah, can treating GERD prevent the progression to more dangerous health conditions?
Yeah, I mean, GERD, the main, and this is where you have to be careful, saying things, because I think people can get scared. The main reason for the increased adenocarcinoma of the esophagus in the United States is because of reflux. So reflux results in, there's a direct relationship to reflux and the development of, cancer risk in the esophagus. Now, that doesn't just happen suddenly overnight. It's not like one day you have reflux and you're going to get cancer. It's just not the way it works. But again, that's why the persistent symptoms should potentially be looked at, discussed, and evaluated for the lining by an endoscopy. And the reason is we do see things like changes in the lining, such as Barrett's, and with persistent reflux, that can result in something called Barrett's esophagus. And that's when the lining of the esophagus starts to change because of, kind of recurrent erosions. Think of it as like something scratching your hand once here. Nothing's going to happen to your arm here. But if I scratch it like this 500 times and I sit here and scratch it, and then I come back, and you come back in an hour and you look at it, it'll probably be kind of red. If you do that every day for a year or 2 years, 3 years, then it starts to it starts to hurt the esophagus. So the short answer is yes, it can lead to things. The reality of that is, not everybody needs to run to the doctor because of reflux once in a blue moon. It's really the persistent symptoms that are not responding to certain treatments. But there's no harm in having these discussions with your primary doctor and even a gastroenterologist. And if you fit the bill and you've had chronic issues, to have an endoscopy to evaluate things, get a baseline evaluation to see where things stand if there's concerns. And then there's other things we talked about. So you can get ulcers in the stomach if you have pain and abdominal pain with acid levels. And and you can have let's say you have chronic persistent asthma, which is not your typical case, but someone has asthma persistent despite treatments with inhalers and such, and they're found to have acid and reflux issues. And in those situations, it could lead to worsening asthma or pulmonary related issues and such. So things to think about. I think that you definitely don't want to ignore your symptoms. They're worth having discussions and evaluations especially if they're persistent.
Yeah.
Very good. Thank you. I love that analogy of just what a chronic condition does. That's awesome. Thank you very much. Andrea, back to you.
That's exactly what I was going to say. I'm like, that's such an easy concept to fathom, right? Your hand or your arm and just continuous, consistent irritation, if you will.
Yeah, it's like a chronic, exposure, like anything, right? Anything we do, if you run, if you're a runner and you run a ton, you might have, you might sprain your Achilles if you run, miles and miles and miles every day.
Yeah. So let's talk about treatment options. We discuss, or a lot of the times we talk about PPIs, and then maybe talk about the different types of procedures that are available for GERD at this time.
So yeah, I think there's a kind of a spectrum of issues here. Obviously people and everyone has been aware of acid reflux medical treatment with proton pump inhibitors and H2 blockers such as Pepcid and the number of medications out there to prevent acid reflux. The spectrum kind of goes to the other side of it, where patients can have large anatomical issues. Patients can have hiatal hernias, large hiatal hernias, or even small hiatal hernias, or some patients just have persistent acid despite medical treatment. And in those patients who have been evaluated and have had discussions, there's other options of anti-reflux treatment options, which can include endoscopic treatment of the sphincter, of the lower esophageal sphincter, and making we talked about acid making its way up the other way, and essentially kind of tightening that valve where things should be kind of a one way, so that not as much acid would flow upward. And now in 2021, we're discussing things that transoral incisionless fundoplication, which is done endoscopically, making that lower esophageal sphincter tighter, and in many times in conjunction with a good GI evaluation to look at anatomical issues of the junction there, that the esophagus to the stomach, where you can see these hiatal hernias that can be sometimes small, sometimes large, but may need to be discussed for surgical correction and doing the fundoplication at the same time. There's the traditional methods on the for making the sphincter muscle or the lower esophageal sphincter tighter, and that would be a surgical approach,
Sure.
which would be a Nissen fundoplication. So there's kind of the side of the kind of surgical management to the far right. There's the the medical management to the left, and obviously we talked about lifestyle. So we have a spectrum of treatment options, and I think all of them are important to discuss. So
yeah, perfect. Thank you. I hope that's not a urge age that you need to get to.
No, I'm sorry.
No, it's okay. I want to make sure there's not a patient on the other end waiting for you. So I want to be cognizant of your time. So
I appreciate it.
Okay, no worries. One question we get all the time is, what is the difference between the TIF procedure and the Nissen, the standard, or what they so-called the gold standard procedure, the Nissen procedure?
Yeah. So and Nissen has been done for, many, many years. And it's kind of, it's still a great procedure. There's, you know, we have computers that work, and they're good, and they might be, older, and they may have a slower processor, or they may have an older Windows or whatnot. They still work really well, and they're still good, and they still function quite well. And it's really just as time has evolved, the menu of options, and with the scale of technology, there's more options available. And the Nissen classically is done in an operative management setting. So it is done typically in an operating kind of a fashion with, and I apologize, but they keep texting me,
They probably are watching you live.
Not her, yeah. But it's done, generally in an operative fashion, and the classic Nissen fundoplication is taking a 360-degree, tightening of the esophagus. So if you can see my hand, and you take an esophagus that's, the lower esophagus, and then you tighten it, but then you keep tightening it like this, 360. So that's kind of making that area really what the surgeons and the GI folks will call a wrap, a pretty tight wrap. And it traditionally will involve the fundus of the stomach, which is the top of your stomach. Whereas just to compare, the transoral incisionless fundoplication, the TIF, is done in a similar fashion, but done endoscopically, incisionlessly, and also with a 270-degree wrap, we can call that. And again, if you look at the hand analogy, it's taking it, but it's going here. It's not taking it all the way around. So you can imagine if one of the issues with the Nissen classically, or one of the kind of things to discuss and think about, are involving that stomach. Patients can sometimes have complaints of bloat, gas discomfort, which can be, something to discuss and think about. And again, the menu of options are all good, and they're all important, and they all need to be discussed, and they all have their role. But there's more options now, and so these things are worth discussing, thinking about, and entertaining with the doctors that you're seeing, your providers. So
perfect. And one thing that patients these days are concerned about is being on PPIs for an extended period of time. Can you talk a little bit about that? Are there long-term side effects to long-term use of PPIs?
Yeah, I mean, generally speaking, PPIs are a great medicine, and they're safe, and they're generally well tolerated. But there's a difference in and we have to respect the decision of patients that may not want to be on it long term. For example, just a young patient, let's say, who's 30 years old or 40 years old or whatnot, and someone who doesn't want to commit to their life if they're continuously on this. And we've taken care of patients that are much older who do not want to be on these, and it is a preference. Some patients have anatomical issues which cannot be fixed with medicines. So it's important to kind of think about those things. As far as the data on the medications being kind of side effects, so to speak, or not well kind of tolerated or long-term effects, which people like to discuss. So, I think everybody who may be on this forum has probably looked at it or seen things on New York Times or CNN or whatnot, and seen associations. So it's important to know that there are associations with these medicines with long-term kind of reported long-term issues, including kidneys, dementia, having B12 malabsorption, and many other things, renal disease, etc. So I don't think that there's one particular mounting issue that people, C. diff infections and everything. I don't think there's one particular issue that people should necessarily kind of hone in on, but rather that there just seems to be more and more accumulating things that are showing up that is making people concerned. And so I think they deserve at least a discussion, again, a discussion with their doctor, with their provider, and maybe this patient would want to consider non-medical options. And medicines work fantastic, but many patients don't want to be on them for these concerns or for whatever reasons. Again, no one shoe fits all, and I think it's worth a discussion. And for some patients, the medications are doing well and they're doing great on them, and I think it's completely appropriate to stay on these. I think the data is still mounting and we're still learning a lot. But given the unknowns with many of the adverse effects or side effects that have mounted in different parts of, we've talked neurological, we've talked kidney, we've talked GI, C. diff infection. So the multi-system bone loss people bring up every now and then. So all these types of things, again, with all of them, folks tend to get a little bit more nervous, and I think rightly so. I mean, I think it's worth discussing.
Yeah. Perfect. Thank you. And I believe, Wendy, we've got quite a few questions that are popping up, or something in particular to PPIs.
Sure. So we did actually have several questions come in as you were talking about proton pump inhibitors, and kidneys. I seem to see were of particular interest. I think you've touched on that already. One thing that I wasn't sure if I missed this. It seems to be that as I talk to a lot of physicians throughout the country about this and ask them, how do you feel about PPI treatments? Universally, they say much of the same of what you said, which is if it's working right now, that's great. If it's, however, once it's not, then what, then the discussion really needs to happen. How confident are you on doubling up or tripling up dosages? We have patients that ask, when is the right time for me to say, okay, this isn't working, it's time for the next thing?
Yeah, I mean, if you're well controlled and there's been really no changes and you're overall doing well, and again, no alarm symptoms, then, many patients are completely fine. I think it's really, as you said, when you're starting to have refractory issues, that nothing's working, or all of a sudden you've been told to double up because your symptoms are recurring, or you're taking an extra Tums on top of things that, it's important to look at, I at least in my opinion, to consider anatomical issues. Could this be an anatomical? What if there's a large hiatal hernia, or a moderate size or small, or whatever? What if there's an anatomical hernia to explain a hiatal hernia to explain some of these issues? And I think that patients that are having recurrent problems. Again, you said, I think your question was, what if you're on him once a day, but then when's the right time? When's the right time to go see my doctor or get an evaluation? I think that, there's whenever, if you're probably on this forum and you're thinking about it and you're looking at it, it may be the right time to think about it because it's bothering you. It's bothering your day-to-day lifestyle. And I think that if it's something that you're concerned about, that you want to have a evaluation for, I think that that's reasonable. Obviously, taking alarm symptoms aside, if you're comfortable on once a day, then that's completely okay. But if you're upping your medicines, if there's a change in your heartburn symptoms, and it's relatively persistent, new, or ongoing, you should be evaluated.
Excellent, thank you. So you've touched on hiatal hernia a couple of times, and we do have some questions regarding hiatal hernia. And those basically just are what if I have a hiatal hernia? What can be done? What are my options? And if Nissen is something that addresses that.
Yeah, absolutely. So, again, they kind of go hand in hand. Reflux is related to acid coming up. It's a weakness of that lower esophageal sphincter, but on top of it, it's an anatomical issue along with that, often, not always, but often with a weakening of the diaphragm muscle that's holding things in place. And so you slide your part of your esophagus into the up above your diaphragm, and that leads to some muscle weakness of the sphincter muscle as well, which results in reflux. So it's kind of, for someone who's not like looking at pictures and discussing it, can get a little confusing, but they can be a hand-in-hand issue. How do you know if you have one? Typically an imaging test and an endoscopy. So, or an endoscopy. So an endoscopy can give you a lot of information. You can look at that directly. You can see what's going on. And an imaging test sometimes can be in conjunction very helpful, because you will see those similar features potentially on those X-rays with contrast. So together, these things are important. At our center, I was telling Andrea and Wendy this before, is that we do a multidisciplinary. So we collect information. We look at upper GI. We look at the endoscopy. We have multidisciplinary discussions with our training program and presentations of the pH study we talked about. So all the things we talk about, we kind of discuss all these tests, and we reevaluate them and make decisions with patients to decide if what options are best for them. So everything from medical to Nissen fundoplication. So but yes, the Nissen is similar to transoral incisionless fundoplication, similar in that they're wrapping. We kind of went over the differences, but the hiatal hernia is typically done as a surgical procedure. So the hernia, it can be corrected with the aid of a surgical expert who will then fix that area, but then follow it up with a Nissen, which is a fundoplication, which is incisionless.
Okay, very good. And then, or it can also be followed by TIF, correct? Is that?
Yes. Oh, yeah, that's what I meant. Yeah, but followed by TIF. Yeah. Typically, at our site, we're following them with TIF. They can be followed with Nissens, but again, some of the issues with the bloat, gas, discomfort, and with the success that we've seen over the years, again, things work, but there's things that are new and innovative and perhaps quite a nice option for many patients.
Perfect.
And do you see in your practice, is that a frequent occurrence, a hiatal hernia, or is it pretty uncommon?
We do see a lot. We see a lot of hiatal hernias in conjunction with reflux disease, and I think that's probably why I've been kind of saying some of that while we've chatted. I've chatted a little bit about it, because oftentimes they do go hand in hand, and we see that a lot. It's not always, but certainly it's a common scenario.
Very good. One last thing, and then Andrea, I'll turn it back over to you. We have Lori asking about silent reflux, or LPR. Can you elaborate a little bit on that, and if PPIs are effective for that, or is TIF something that is indicated for that condition?
So, LPR is laryngeal pharyngeal reflux, and patients can present with that. We talked a little bit about asthmatics or people with pulmonary issues or lung function issues, or people clearing their throat a lot or having some sour taste in their mouth and such. So it may be silent. Sometimes if you talk to your doctor, they may be able to elicit. The silent may not be so silent if they talk to their docs and they're able to say, oh, well, you doing a lot of this? Are you having a lot of reflux? Are you having a lot of throat clearing? Are you having pulmonary issues, etc.? So sometimes it may not be so silent, but I can tell you anecdotally, we've had many patients with laryngopharyngeal reflux and have done well with TIF procedures and correction of the reflux. I think it's important, in my opinion, to not just run to that as the answer right away, but to rather get the workup, get the proper workup to see. Because if you are a right candidate and you have these symptoms, then I think that it could very well be a very successful treatment option. But we need to confirm things. You want to confirm acid. You want to confirm that there's no other issues related to postnasal drip or any other kind of complaints. But there certainly are good options for that condition if you do the workup. So if you do the right workup and you're the appropriate candidate.
Excellent. Thank you very much. All right, Andrea, back to you.
Thank you, Wendy. So let's talk about recovery. Well, let's talk about kind of post-op procedure, and then what does recovery look like? So are they in the hospital for, a night? Or are they in for longer? And what does their diet look like? What do they have to do typically after the TIF procedure?
So, we typically like to have our patients stay just at least overnight, just for observation and introduce the diet and make sure they're feeling well. I recently did a patient who she was an elderly when she was an elderly woman, I think, and we took care of her, and she had her TIF, and she said, "I'm not staying." And it didn't matter what we said, she was leaving. She said she felt fine, and some people are just, they're gonna, they're tough, and they're tough cookies, and they're fine, and it's completely fine. I think most patients probably could do well. We tend to, at our site at least, we tend to just watch them overnight. They, most of the time, they're let's say 99% of the time, their patients go home the next day. We monitor their clinical course overnight, but generally speaking, post-operative recovery is pretty straightforward. There is a dietary modification which is important to abide by. The first couple weeks is a very limited diet, and we provide our patients dietary instructions because, importantly, again, getting back to lifestyle, it is important to treat yourself well and do things that are good for you. So, I think the wrong thing to do would be kind of irresponsible of us to say, yeah, go and, have 3 cheeseburgers now every day. That's not right. All of us kind of know that. So we do have to use our common sense and health kind of parameters that we all know about. So, be good to yourself. I think the first couple of weeks is really liquids and soft foods as are slowly introduced. And, over the course of the next 3 to 4 to 5 weeks, we start to introduce more solid foods and start to kind of integrate more of a regular routine diet, but with responsibility from the patients and discussions with them about, eating properly and spacing out meals and smaller frequent meals. And, once we get past the first, 6 to 8 weeks, we start to open things up where they can get back closer to a more regular diet or a more normal diet, where they can start to advance into a pretty healthy regular lifestyle and feel well. And again, the goal is to improve your quality of life in patients that are having these procedures. And I think the data has shown that the quality of life can be improved in patients that have these procedures, with many of them even coming off their proton pump inhibitors. And so it's important that the goal, again, and I always tell this to patients, what's the goal? If the goal is that you want to improve your quality of life, and that's what you want to do, and no matter what the PPIs have said, but if you're refractory, you're not doing well to it and not tolerating them, etc., But regardless of all that, if you wanted to improve your quality, then those are the things that I think make it important to discuss options.
Oh, wonderful. Thank you. And what about exercise? Can they get back to exercising, within a reasonable time, or what do you normally recommend to your patients?
Yeah, I think within a reasonable time. I mean, I think, generally post-operative management in general is to reduce kind of heavy lifting and such for the first couple weeks and things. But technically speaking, from the a TIF perspective, it's really, not an enormous limitation. As far as, how quickly you want to jump back in, there's general rules from post-operative standpoint, but I tell patients don't jump right back into something like heavy lifting or weightlifting and things like that. Obviously, walking and exercising and doing your routine kind of day-to-day activities and are perfectly fine. And within a 3 to 6 weeks, as things are improving and starting to get better and tolerating more foods, I think exercise is also integrated back in. Everyone's a little different too. Some patients, like I said, that patient wanted to go home the next day, and maybe if I told her not to lift weights, she would lift weights regardless. So, but in general, we try to just be cautious with some of those things and be aware of post-operative general instructions of slow introduction back into normal.
Give your body some time to heal, right?
Yeah.
Well, we're getting close to the top of the hour. Before we conclude for the evening, I do want to give you an opportunity to provide any words of wisdom to any of the potential patients that might be watching today. What would your recommendation be to them if they were suffering from GERD?
Pretty straightforward. My general kind of, I'm a very honest kind of normal person. I think that if you're struggling, just come get evaluated, whether it's with your primary and you need a referral, or if you can get directly with a gastroenterologist to be evaluated. Obviously, if you're thinking about this stuff, it's bothering you and it's concerning you, and I think that it deserves a discussion and an evaluation. And the other thing I would say is an endoscopy in general, if there's concerns about that. I know someone mentioned how invasive. I mean, I think in general, just a standard endoscopy is a very, very safe procedure that's done by gastroenterologists routinely every single day. So if those types of concerns are on the forefront to mitigate, then let me tell you that would be a relatively low risk evaluation. But yeah, I would certainly be evaluated, be seen, and have discussions.
Fantastic. Well, thank you very much. And if you are watching and you are in Pennsylvania, you can see Dr. Shah. If you're not in the area, you can go to gerdhelp.com. We do have a physician locator, and you can put in your zip code or your state, and you'll be able to find a TIF trained physician near you. So again, Dr. Shah, we can't thank you enough for joining us this evening. We really appreciate it. I know the people that are watching appreciate it. And to everyone watching, thank you for joining us. We'll be here next Tuesday for our TIF Talk. Until then, please stay safe out there and have a great evening, everybody. Take care.
Thank you.